All right, welcome everyone. Excited to have you all here. As we wait for some people to join in, I would ask if you have a clinical case, just feel free to type your clinical case in the chat. Just give me a clinical case that we'll be discussing in the course of today. Remember, the talk today is about using AI in emergency care. So just put a story anywhere on the chat about a patient you know of. Of course, don't give me patient details. You can put this in the chat in the Q&A, and then we'll just go automatically to managing cases using AI and just for you to understand how AI works in patient management. So I think we still have, can give people a few more minutes to join in, but please put some questions in the chat, or some questions actually, patients. Say a patient who's coming coughing blood, and I'm worried about that patient. And we can go through a lot of cases. So this is a very interactive session today, where most of the work will be with you and us managing cases on using AI. All right, we'll give people 2 more minutes to join in. I see that people logging in still. So feel free to put a case in the chat in the Q&A, and we'll be able to action it. All right. I think most people have joined in. So welcome to our session today. And good to see all of you here. My name is Dr. Ashira from the Emergency Medicine Care Foundation. Sorry, we couldn't do this last week. Normally, that's when we have our monthly webinars due to some logistical issues, but we are back this week, so we pushed by a week. And thank you for all for joining today. Why we decided to have this session actually was triggered by a case that was shared in one of the WhatsApp groups, our WhatsApp group, where people were questioning patient management. And so we thought, and yes, there were some questions about patient management of that case. And so the question was, why in 2025 are we still struggling to manage patients appropriately, to give patients appropriate drug dosages, to diagnose patients properly, to order the right tests? And so we thought we'd use this session to look at AI and how you can potentially use AI to manage patients in the emergency centers or in your ambulance services. And we all have a phone. You all have a phone. I think you can see the phone somewhere there. Yes. And you all have access to internet or at least have some bundles. And you all can download different AI platforms. So I'm not necessarily going to discuss which platform is better for what, but specifically, or um, what are the different types of platforms. What I'm gonna share, let me just share my screen. All right, as you can see, I have different platforms set up in front of me. I have ChatGPT, which I think is most of you know. To get a recording later, yes, all of these projects all these videos are recorded about. I have Claude. So this is chatgpt.com. It helps if you actually have an account. It's always good to register yourself with all these accounts. I have no now. I have Claude. This is Claude.ai, uh, which is also a very good platform to be using. Microsoft Copilot, which you all know about. And I can do try GPT-5. Let's see, there we go. All right. And then so ChatGPT and Microsoft Copilot, more or less the same thing, same people. And then I have Google Gemini. Yes, this is Gemini 2.5 Flash. Let me use Pro. Okay. Um, yeah, there's new editing. Yes, and so these ones are free. At least the only one I currently pay for is ChatGPT, but the rest are more or less free. And even ChatGPT is free. You can access it for free. So as I mentioned earlier, this is very interactive. So if you can feel free to put patient case in your chat there or in the Q&A, and we'll manage these cases step by step. And I'll just give you an example. And so feel free to put a case in the chat. But if I could start here, and the good thing about AI, remember AI, so there are a couple of things that when you're using AI for healthcare that you need to be cognizant about. Number one, AI does not replace your brain. Okay. You still need to have gone to a healthcare provider training. You still need to know what is factual. You still need to know what potentially is right or wrong because AI can easily be misleading. But you also need to understand to have a good idea of be able to detect what is the AI is giving you that may be right or may be wrong. Um, and be able to decide the best way forward for your patient. Remember, at the end of the day, it's not the AI treating the patient, it's you as a healthcare provider. And thus, it's important for you to think through how you're managing your case and your patient. And so I'm just going to start with a simple case. So let's say I'm sitting in the emergency department. I think you're all seeing the screen. I have a 43-year-old man complaining of chest pain. Okay, it's a very simple case. Uh, so my question, that's the other thing is, so number one, you need to give the AI the context. So I have a 43-year-old man complaining of chest pain, and I can say in the emergency department. And I can ask a simple question, not like, what should I be worried about? All right, let's see what the AI gives. Okay, and so you can quickly see it says, in a 43-year-old man with emergency chest pain, your primary concern is to quickly rule out life-threatening causes. So the moment I mentioned I'm sitting in the emergency department, then immediately it picks up that potentially needs to rule out what is life-threatening in the emergency department. Several conditions can rapidly progress to disability or death if missed. So the keywords, it's telling me acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, pericarditis. It's even given me what needs to be done. Okay. So air breathing circulation, I need to do an ECG within 10 minutes for ACS. Vital signs, I need to do blood pressure for both arms, heart rate, respiratory rate, SpO2 temperature. I need to put an app on IV access, put the pressure to monitoring, take a focus history and exam. Initial investigation. So remember, so it's given me all these options, all right, from just my initial discussion. So um so these are the conditions. So this patient has, so I started with a 40-year-old man presenting by spastic chest pain. And so it's given me all these red flags to think about. I'm okay. I'm like, okay, so when I examine the patient, I find he is non-diabetic, diabetic, and hypertensive. I'm giving the AI a bit more information. Um, so as you can see, it's now narrowed down quickly to uh, acute coronary syndromes, all right? And it could have a hypertensive emergency. That's a new one. Severe hypertension still says aortic dissection is a risk factor. Uh, oh, okay. All right. Ivy Muya wants us to change to wilderness. I'm gonna do that. All right. So chest pain. So I need to get an ECG now. All right. And cardiac monitoring, troponin baseline. I need to do one now. AV access to that, bloods, chest X-ray. Okay. So again, more information. So it's diabetic hypertensive. So I'm worried about ACS. So I'm definitely going to do my ECG, set up my V access. But I can also say he had an episode of massive vomiting and now has shortness of breath. Let's see what happens. All right. So, aha. You see, things have quickly changed. This is new information, as you can see with the AI. And now it's because of the vomiting and shortness of breath, then my things have changed, priorities have changed, and this is where it has quickly brought up what is called Boerhaave syndrome, which is actually what I was trying to come up with in my head. So forceful vomiting, sudden severe chest pain, and shortness of breath is a classic presentation of esophageal rupture. Pain relates to the back or shoulder. So I can ask the patient, do you have any pain in the back or shoulder? And the patient may say, yeah, may develop subcutaneous emphysema, septal shock, high mortality if missed. So now my question is, here, if you suspect Boerhaave's, I suspect, so I'm gonna do an X-ray. So let me see, what should I find? I'm gonna do an X-ray to do an X-ray as I suspect Boerhaave syndrome. Let's see what it says. So what to look out for X-ray? I need pneumomediastinum, pleural effusion, often on the left side. Okay, good. Or hydrogemothoracic fluid. You should need to look for pneumothorax, subcutaneous emphysema, widened mediastinum. So that's needed. I'm not going to ask for an image. So I normally can ask for an image, but here we go. Would you like me to create a one-page Boerhaave's AD protocol? Yes, I can say yes. Yes, give me one. Yes, create one. Mhm. Okay. There's your clinical trigger. So we need to get oxygen. If SATs are above 94, give IV accesses, resuscitated fluids, nil pulse, chest X-ray, pneumomediastinal fusion, pneumothorax, within mediastinum, subcutaneous emphysema, other CT chest with contrast and different labs, immediate management, red flags, bottom line. All right. So I'm gonna take IV's every suggestion that we change the case. So what I'll do again, because AI works with what you've been talking about, I'm gonna create a new chat. Okay. I'm gonna create a new chat because if I continue this chat, then the patient will still be in the ED. So okay, let me change. So I'm gonna create a new chat here. So I'm gonna say the same case. I have 48-year-old man with chest pain in and they're in the bush, chest pain. All right. Um, a bush medic and currently in the wilderness. What should I be worried about? What should I do? So now we've changed the environment. Let's see what happens. All right, in a very high risk situation in the wilderness, limited resources, let's break it down what you need to worry about and what you can do right now. Okay. Uh, so it still gives you what the different diagnosis, what you need to worry about. Okay, what can you do right now? Sit or leave the patient comfortable position, ensure air is open, put your patient on oxygen, call for evacuation as soon as this may need hospital urgent care. If you have aspirin and no contraindication, give aspirin. If you have GTN sprays and systolic blood pressure, that's assuming you can measure these things. Okay. And your patient is not on Viagra, please don't give them nitroglycerin. If he's very breathless after vomiting, look acutely well. So it's picking up from a previous conversation. Monitor signs of shock, record time, those are red flags, give us a possible urgent evacuation, keep him monitored and suspected. So as you can see, the scenario has changed. About to be replaced by AI. No, Peter teach. You're not, in fact, I wish you would replace your own brain with AI. No, I'm not saying that in a bad way, but we have so many people who are guessing in medicine. Remember, our training was based on us memorizing everything in medical school and regurgitating it to patients. We need to really move. The world has moved. We need to use technology to improve our accuracy, Peter, to our accuracy of the care. Remember, this will not replace your brain. Similarly, and let me go back and show you something. So I'll go back to this patient which I had. Let me get off the wilderness. Let me go back to the AD. I can say here I have auscultated the head, the chest, and there are no breath sounds on the left. Okay. He is also diaphoretic. So same case. So remember, AI will never do the physical exam. So don't worry about you being replaced. So I've changed the scenario a bit. So now he has absent breath sounds on the left. And so tension pneumothorax is therefore distress. Okay, massive left pleural effusion. If unstable hypertension, severe treat as tension pneumothorax, needle decompression in the second intercostal space. So now again, the AI will not do the needle decompression. Unfortunately, that will have to be you as a healthcare provider. Chest tube insertion on the left. Have an ultrasound. So I can say, so in this case, let me say I have an ultrasound. How can I confirm this? Excellent. All right. Good. So, of course, you must know how to use the ultrasound, but I can look at if it's normal lung, I can see bit lines, lung sliding. If it's a pneumothorax, absent lung sliding. Treat as a pneumothorax, pleural effusion, I can see an echoic and echoic. So it tells me exactly what to look out for. And here are my decision points. Yes. All right. So guys, let's come up with more cases. Here's a Q&A. Same case in an ambulance, 30 minutes away from the ED. So Jason, I'm gonna take your case. So let's get a new chat, just so that we are moving away from the ED. As you can see, it says good to see you, Ben, because that's my AI. Same case. Let me just go pick up the details of the previous case, chest pain concerns. All right. So, the person who still has to make a decision is you. It's you who as a healthcare provider, no one else. Yes. Um, the AI is just helping you think through the process. New chat. Uh, Here we go. So I'm a 40-year-old man presenting with chest pain. Um, and 30 minutes away from an chest pain in an ambulance and 30 minutes away from the ED. What should I do? What should I do? Let's go there. Okay, so ABC still, administer oxygen subs, monitor SpO2, auscultate, treat hypoxia, circulation, check DCS, hypoglycemia, quickly inspect this. Immediate concerns are that aspirin, morphine, fentanyl, ECG, IV access, the usual. Red flags are that pre-alert the AD, share symptoms. All right. Early ECG if possible. Okay. All right, can you give me a structured handover template? But let's complete. Wait, I'm seeing something on the chat here. So Q&A. ECG findings. All right, so answer live. So I will take anonymous ECG, anonymous attendees question. I have an ECG. I have an ECG for this patient. How do I? So that's what the person has asked. How do I differentiate? How do I check? What are the ECG? What are the ECG findings on the difference between SVT, labyrinth, and VTAC? I don't know. Let's see AI. The good thing about AI, you don't even have to type accurately. Um, okay, so we need to figure out which is which. All right. So essentially, VTAC above 35, our patient's 45. With structural heart disease, prior MI, cardiomyopathy. So I'm probably working with VT at this point based on my patient's age. Spontaneous, often usually regular, regular, but if very present, independent atrial activity period is not related to QRS, structural diffusion. QRS with more than 140, usually less than 140. Extreme axis deviation, Access normal on this side, concordance, morphology. These are all your differences. Yes. I suspect my patient is having a heart attack. So which is it? All right. So again, you can see telling me the issue doesn't really matter whether it's aberrant sequential tachycardia. It's not really a big thing to discuss. Who cares? All right. Question is, it STEMI or not STEMI? And then VT is more common than acute MI in the first, but less likely. So this is less likely. So we're probably dealing with a VT patient and has a VT now at let's say 160. What should I do? All right. So he's unstable. Oh, I need to check stability. All right. Says stability. Okay. Call for backup, cardioversion. Okay. So my patient is unstable. His BPs are low. How do I cardiovert? Do I cardio? Please help. Please help. All right, so attach monitor to that, one part below, tells you where, stop IV access, sync mode, look for markers above each arrow, eventually shuffle the one arrow on. If possible, give some sedation, energy selection, such as 100, escalate to the, okay, as you can see, it has step-by-step procedure as to exactly what we're to do. And uh, here is the cool part. So I could easily just click here, dictate. Let's see if this works here. Um, while visiting the site. Please read out for me the instructions of cardioversion so that I can do them real time. All right, so that was just me talking. I can't hear anything. On your phone, it works. It can actually read out to you. What's the script? Wait, am I listening? Anyway, normally it will talk to me on my phone. All right. So good. Here's another question. So I've answered that question. Guys, let's come up with questions. Let's test the accuracy and how good this is um, to discuss different patients. So far we've managed one patient who has multiple chest pains. I'm just gonna delete these cases. Otherwise it clogs up my all right, and then we're gonna discuss. So I hear a chat there, Q&A. All right, thanks, Julia, for that. I'm just gonna copy that and let's come up. Julia has given us a new case. So let's look at what the case looks like. All right. Call center dispatch to a female patient, no known personal medical history, but then complaining of chest discomfort. This one of 2 days on examination. She has to keep near that. Desaturating, it's gonna change that to that. 61 room air, good air entry with no adventitious breath sounds. BP is up, peripheral pulses, cold extremities up to the elbow and knee. Cold cap refill is that GCS 15. It's a BLS apart from oxygen saturation. What should I think of? Good. All right, let's see. So your patient is very unwell. Oxygen alone may not be sufficient. Okay. So patient is severely hypoxic, as you can see. Patient is quite tachypnic, which essentially tells you now your patient is about to stop breathing. Okay, so this is information you definitely want as a BLS crew to know that your patient will stop breathing shortly. Cold periphery, poor peripheral perfusion, normal GCS, but it's still compensating, but could deteriorate rapidly. Again, so the following causes of silent hypoxia with good air entry. So patient either has a massive PE, something to think about. Um, Severe pneumonia with ARDS or any features of fevers or history of fevers. If it's sudden onset, probably PE is what you're dealing with. Chest pain with pulmonary edema, so you have to listen to the lungs. So maybe Julia, what did you tell us the lungs have? No adventitious bed sound. So lungs are clear, so less likely at the less early stages may present before adventitious bed sounds. Though lungs currently clear, evolving life ventricular is possible. Sepsis may precede obvious fever and source, tension pneumothorax, so less likely. Okay, so priority for you, a BLS ambulance, put them on non-rebreather oxygen, proceed the patient upright if tolerated, unless BP drops further, monitor for deterioration, rapid transport to the nearest emergency facility with resuscitation capacity. So it's even telling you, don't just go anywhere. You need to go to a hospital, call for, so an ALS intercept. Sometimes you probably want to call your colleagues who have advanced life support to come early and help you in way, conscious monitoring, early pre-alert. Beyond oxygen, and spare the need for that, request ALS early. So you want to call your ALS group to come and support you. So, and they can meet you somewhere. So remember, your patient is going to crash at any point. You said you are how, did you say how far you are from there? No, you didn't say how far you are from the emergency department. But yeah, so if you're far off, then you may need to ask your ALS to come and intercept you. Um, so run. But as you see, so also when you're taking your patient to a facility, then the facility for sure, ideally, technically should have a CT scan, but most likely your patient will just a bedside ultrasound with the emergency department will help this patient because this patient will not last a CT scan unless they're stabilized fast. So Julia, that's your question. You want to complicate it further? Let me know. Um, Okay, so I'm seeing multiple questions coming in. So let me deal with this. So that was Julia's. I've answered live. Um, Dan, Julia, feel free to complicate it further. All right, I have another case. All right, maybe Muya, let me take your case. Okay, so I'm just gonna delete this. The problem again, if you ask that question here, it'll think you're still dealing with the same patient. Um, but let me add it like also it also clogs up over time. It clogs up your AI. So when you're done with stuff, always delete your otherwise you fill up your memory, which sometimes not that helpful. So this is IV. Oh, sorry. Let me copy Ivy Muyan's case here. Copy that. Why is it not copying? Sorry. All right, 6 seconds. So I'm just gonna remote site medic called to assist an unwitnessed suspected snake bite. What do I do? What do I do? What's the next? What do I do? What's my question? What questions should I ask? I do not have anti-venom. And the snake can't be seen. All right. Yes. So what do I do? All right. Let's look at what this says. Okay, patient is away from danger. Do not go looking for the snake, please, kindly. All right, keep the patient calm and reassured. Movement increases venom spread. Remove rings, bangles, watches, tight clothing near the bite site to prevent constriction if swelling occurs. So the key questions to ask is where was the patient? What were they doing? And is excited? What time of the bite or suspected bite? Local symptoms there: pain, swelling, redness, bleeding, fang marks. These are the red flags to watch out for: nausea, vomiting, dizziness, collapse, difficulty swallowing, drooping eyelids, difficulty breathing. So, and these are hematotoxic symptoms, neurotoxic symptoms, and cytotoxic symptoms, usually the swelling and things. So you're looking this out to look out for: first aid, immobilize affected by splints, like a fracture to reduce venom spread, keep lymph below the heart, broad compression bandage, okay? Only if neurotoxic snake, suspected cobra, and you're trained to do it. Key things: improper technique can cause harm. Do not cut, sack, wash the wound, apply tonic care, apply ice, IV access. I don't know, you're giving oxygen, but I guess you're in the field fine. IV access, treat for shock if present, manage pain, evacuate. Patient must reach a facility with antivenom and sufficient capacity. Yes. All right. Let's say, okay. So the key question here is, let's ask it this way. I suspect it's a harmless snake, but not sure, and evacuation is far. So and this is far and expensive. Let's call it what it is. All right, and expensive. Anything I can watch out for to delay evacuation, especially if uh, it was a harmless snake. Let's do that. Uh, okay, so good. So up to 70 to 80% of snakes are dry bites, no venom injected. So features suggesting less likely harmless or dry bite. No fire marks on facial sashes, no progressive swelling after 1 to 2 hours. Minimal local pain resolving with basic analgesia, no systematic symptoms. Okay, so if I'm not saying any of this, most likely uh, red flags that require evacuation, even delayed. So, is there any of this happening? Blistering, systemic effects. So then, yeah, okay. So, practical monitor. So, first 2 hours monitor. So, local pain swelling, keep the limb mobilized. Check every systemic signs often appear within this period if venom is injected. Okay, so a couple of hours. So, at least I can do watch 2 hours. If asymptomatic after 8 to 12 hours, no progression like good. Right. So at least I have a plan now. So I can say, okay, so we're gonna watch this patient. They seem to be less likely it's a dry bite, but these are things I'm monitoring my patient for, then we'll decide whether to evacuate or not. All right, good. Uh haha. Okay, Dora Sega, let's do your question. All right. Just gonna delete this. I said I normally otherwise they just clog up my system. So as you can see, I love ChatGPT because it's very basic and simple, but there are others and we try and test others. But let's try this one. 1 year old girl presenting with commercials for more than 10 minutes. Oh, sorry, I should say where I am. Yes. Yeah, so tell me where you are so I understand. Okay, but here, so I'm guessing it's picked up. So with AI knowing you, it will definitely know I'm an emergency physician. So it always assumes I'm sitting in an ED somewhere. Prepare as action if possible, advance area support, provide high flow oxygen, establish IV access, rapid glucose check if hypoglycemia, give 10% dextrose 5 ml per kg IV bolus, look for trauma nutrition ashes HSC. First line, I need to give a benzo, zero point 0.3 to 2.3 milligrams per kg, or I can give one of this, midazolam 0.1 gram per kg. If no IV, I can give rectal diazepam. Nobody. That's so now from my clinical knowledge, I know rectal diazepam doesn't work as well. So I'll work with buccal midazolam. Or I could ask, I can give IO. What about what about IM midazolam? Uh, that's what it says because I can't get a line. Yes. So I can give IM midazolam because I can't get a line. Level of absorption, particularly useful in transfer setting or resource limited settings. There we go. And then it's giving different routes, those notes. I can, interesting information. All right, so I'm gonna give IM diazepam because I am midazolam because I can't access an IV line. Uh, so after 2 doses and still go access, so I give phenytoin, infuse slowly, and cardiac monitoring. Aha. So why am I infusing? I infusing phenytoin slowly. How slow? Huh. Oh, okay. For phenytoin causes hypotension, bradycardia arrhythmias, cardiac arrest begin too rapidly. There's too many stories in there. So 50 milligrams per minute. That's for kids. Adults less than 50 up to 50 milligrams per minute. Large bore 1 year old child needing so my child here, I need to give 200 milligrams of phenytoin over 20 minutes, not any faster than that. Good. All right. So that tells me exactly how much to give. And what rate am I giving at? What does it say I need to do? After three, that, and we are still stuck. Oh, I can give phenobarb, prepare to intubate and ventilate, and then all the other things I need to do for my patient. All right, good. So as you can see, I accurately now know how much of the drug I want to give. So I'm going to give 20 grams of electrolyte infused over at least 20 minutes, not faster than this. All right, so that is your case. So Dora Sega, done. All right, next case. Anonymous, let's do this. All right. Just gonna delete this. Your chat. All right. So a 20-year-old female with undifferentiated autoimmune disease, on hydroxychloroquine comes to the AD with dizziness. Is hypoxic, hypotensive, cyanotic, cold peripheries. Oxygen saturation is not improving with increased oxygen supplementation. Feel responsible. What are my differentials? All right, let's see what happens. Okay, so here's how to approach. So 20-year-old female with autoimmune disease on hydroxychloroquine, dizziness, hypoxia, hypotension. Uh, let's see. Uh, yes. So the first differential is toxic metabolic. Methemoglobinemia. I know it says anonymous attendee, but I know this patient. And this is exactly what they had. Okay. So classic presentation, cyanosis, low SpO2, not correcting with oxygen. Hydroxychloroquine is a known precipitant. So most probable based on red flags, methemoglobinemia. So let's see. How do I diagnose? And tells not so how do I diagnose hemoglobinemia in the ED? And I don't know. So the thing that is asking me to have, let me see. Next up, CD, bedside echo. These are just rural things. I don't have ABG with oximetry. What do I require? If I don't have that, so how do I diagnose? Yes. Aha. So cyanosis, patient looks blue-gray, but lungs are clear, oxygen therapy isn't working. SpO2 is stuck around 85%. That's what this patient had. And this is very telling of the SpO2 part. Chocolate brown colored blood. Venous blood drawn appears dark chocolate brown and does not turn red when exposed to air. Symptoms depend on level. Arrhythmias, coma. This is methyl. SATs again, usually 85%, despite, and they don't move from 85%, can switch oxy plateaus. That's very good. Yeah. Okay. So that's how I figure out. So treatment, as here is a treatment. Stop the offending drug, give oxygen, give methylene blue DA over 5 minutes, contraindicated in these patients. Support circulation is required. There we go. We just managed that patient. Well done. All right, let's go to the next patient. So, and again, just highlighting AI, we should be improving healthcare practice and patient management right now with AI. No patient should be getting bad diagnosis and what I'd like to call witchcraft. Like we have the tools to improve care for our patients in the best way possible. All right. Let's see. Irene Odipo, let's take your patient. Okay, so new case. Ah, how should one handle a fatal sudden right-sided headache, deviation of the mouth to the right, can't speak, no non-history hypertension, management criteria for fibromyalgia. Let me just say in the ED, in the ED. So it's a 43-year-old patient presents with acute neurological deficit, centered with headache, aphasia. Right. So ABCs, the usual. Connect to monitor, check glucose, of course. Use NIHSS stroke scale to quantify severity, document onset. So your working diagnosis is a stroke, okay? Is most likely silent focal deficit, normal BP, no prior hypertension. Your differentials are intracerebral hemorrhage, stroke mimics seizures in post-stroke state, complex migraine, hypoglycemia, CNS infection, or functional disorder. So what you need to do at least is a CT scan within 20 minutes of arrival, some labs. If you're female, you want a pregnancy test. Why do I want a pregnancy test? Let me ask. That's really I want to know. Why do I need this? Uh, okay. Oh yeah. So issues of CT usually first time CT thrombolysis. So it's the treatment for stroke patient. Okay. So, but okay. So it says I need to do an NHISS scale. You can use MD calc for this, but what are the components of this? So give hi. Oh, so it's gonna give a whole process. Yes. Okay, so it's gonna take some time. All right. So there we go. And those are the components. But yeah, just pull out your MD calc and give you that information. All right. So your patient. So question here, because the thing you just said is on management rheumatology for fibromyalgia. Can't speak, no, no, no history of hypertension, right-sided headache, deviation in the mouth. Uh-huh. And quickly also want to ask, because this we have something. Uh Based on the symptoms, where is this stroke in the brain? And I'll explain why I'm asking this question. So it's right spectral frictional weakness, dominant hemisphere, deviated central, first of all, say more than left, that's left hemisphere. So yeah, so the left hemisphere for motor context, yes, the dominant hemisphere is still the left, okay, in most of our right-handed people. Headache. So you're this tells you exactly potentially where the stroke is. So I ask this because sometimes we have patients who fake stroke symptoms, especially those who are chronic ED visitors, and it's easy to tell someone is faking if they're um, what their symptoms put together do not necessarily point to a specific area in the brain, then they're most likely faking a stroke. Yes. So Irene, that's your case answered. On Julia's scenario, uh, Julia's scenario, goodness, sorry, I'm sorry. In fact, let me pick it up. I'll pick up Julia's scenario. All right. Let me do a new chat. All right. So I'm gonna take Julia's scenario. So new chat. So Julia's scenario is that, and then if someone has added the nearest ANS is 20 minutes away, and the closest ED is 45 minutes away. Fine, let's work with that then. All right. V. All right. All right, so we say the ALS is 20 minutes away. So these are the directions. I still think coming up the differentials. They said we think your patient has a PE, start oxygen, airway readiness, continuous monitoring, AV access. Um, ED is for 10, so ALS rendezvous is vital. So because your ED is 45 minutes away, arrange to meet up with your ALS crew. Yes, ALS. So you start driving to the ED and your ALS meets you, okay? Start early transportation towards ALS rendezvous so that you may consider CPR readiness and be prepared to arrest. Yes. Yeah. So start driving towards the ALS, you meet up with the ALS. So that's the continuation of Julia's case. Answer live. All right. Dennis Miriti. Let's see. Let me put that up here. Hooray. Yes. So it's been a busy shift in the emergency department at this rate. Okay, between the ambulance services. All right, so we have a new case now. Young adult presents the ED with difficulty breathing. Patient became ill 24 hours prior to presentation with a fever and progressively worsening sore throat. On examination, is extremely anxious appearing, sitting upright and drooling, in severe respiratory distress, with marked inspiration stridor and unable to phonate. Breath sounds are clear but diminished and difficult to hear supinate transmitted airway noise. All right, so I already know what this is. Let's see what the AI will tell this is. So acute epiglottitis, is a young adult rare disease. So rapid onset, fever, sore throat, progress to be compromised, severe distress, sitting upright, drooling, exam findings clear but diminished breath sounds are due to transmitted by noise. Red flag signs, drooling, muffled, absent voice, inability to lie flat, typhoid positioning. But here are your differentials, okay, which is very important again. So what else could be peritonsil abscess? Even I was actually thinking about a peritonsil abscess in my head before this epiglottitis scenario showed up. Esophageal abscess, tracheitis, foreign body obstruction, angio trauma. So what do I do? Do not agitate. Keep them upright, avoid unnecessary interventions, not attempt throat examination with a tongue. Do not, this is key, eh? Do not attempt throat examination with a tongue depressor. Yes. Okay, agitation, yes, may complete airway obstruction. That you should know about. Yes. Anticipate a difficult airway, so it's a place where you need to assemble a team. Patient probably need intubated shortly, either surgical airway or not. Give oxygen, avoid forcing the patient supine, apply procedures that worsen distress. After securing the airway if unstable and preparing airway is stable, give antibiotics, ceftriaxone or cefuroxime, adjunctive steroids, dexamethasone to reduce airway. Okay, so I want to give, so either way, let me just give antibiotics. What are the dosages for ceftriaxone and dexamethasone? Okay, so dosage 2 grams IV start or 1 2 gram every 24 hours. That's for I'd probably just go with that, make those ones. And then Dexa, I need to give 4 to 10 milligrams IV as a single dose. So I'm doing 10 on the higher side, maintenance 4 milligrams every 6 hours. All right, give antibiotics to skin the area, preparing the answer is urgent. There's not delay antibiotics or intervention, always urgent. All right, cool. Okay, don't stop pediatric. What else am I concerned about? Okay. So I do not have. See, this one says the ETT with fiber. What have this? So of course, I don't have. You don't have fiber optic laryngoscopy. So tell me how to do a ecothyrotomy. In a village hospital with limited resources. All right. Okay. So, start. Okay. So, call for help. If only if tolerated, if not, keep upright until collapse. Administer high flow oxygen. Prepare your blade, bougie, or stiff guide wire. ET tube smaller is easier to pass. If not ET tube or use tracheostomy tube, suction catheter, or even cut down an uncuffed ET tube. Landmarks are those ones. Move fingers down the cricothyroid membrane. Ta -da -da -da. Yes, vertical incision. Ha! What about pain? Yes. So here you see, again, remember, AI is not foolproof. So you want me to cut a patient who's talking to me? Um, yes. So of course, if they start cutting their throat, they're gonna be in pain. What about pain? Aha, okay. Uh, if the prostate is collapsing or high, so they're not collapsing. Okay. So you can give very cautious with, but avoid anything that may depress respiration. So it says they give ketamine. Yes, I'd probably work with ketamine. Local anesthesia, if time a patient infiltrate around the incision site or spread locate the thyroid membrane for incision. So when you treat emergencies, yes, of course, if you treat emergency, you're going down. You're just going straight. It's not possible, but I can probably give a bit of ketamine and do a bit of infiltration of lignocaine around incision site, but do not delay for pain control. Okay, so this is also a bit concerned. But if a patient is crashing, I probably just need to go through the patient down. All right, so that's done. Next case, there's 7 cases to go. Good job. Thanks, guys, for sharing the cases. Let's see. Let's see if we can quickly tackle these 7 cases. So please note, so far the AI has been very accurate. I've not had to question anything. And that's why I'm not counter checking some of the facts, but again, because I know the facts are accurate. So as I said, you need to be able to know what the AI is telling you is accurate. Otherwise, yes, there's a potential chance. So far, there's been no error we've seen, but this is not foolproof. We're still talking to a machine. All right, Jason. All right, so let's do this. I'm dispatched for a call, assaulted adult male for 6 years with multiple stab wounds on the chest. During the call, the patient is talking, but upon arrival, the patient is at you. I'm okay, so I'm responsive. BP is that, SATs are that, with expression of that, and sucking chest wound. Ha. Yes, facility is a local dispensary. Trauma center is 50 minutes away, and I'm with a BLS ambulance. Yo, guys are all asking for miracles. Let's see what happens here. All right. So patient is unresponsive, high risk of airway. If unable, insert an OPA. That's a first, if able. Okay. Place in recovery position if vomiting, secretions, or advanced airway is not available. Prepare suction if you have it. Breathing. There's a sucking chest wound. Apply an obtrusive dressing 3-sided to prevent air entry. If low commercial chest use a plastic bag, dressing wrapper, clean film, tape 3 sides, give oxygen, monitor for signs of worsening, hypotension, absent breath sound severe. So if tension was suspected and allowed needle decompression, second intercostal space, mid clavicular line or fifth intercostal space, anterior axillary line. If not, maintain chest seal and expedite transport. Patient is hemorrhagic shock, BPs are that, tachypnea, hypoxia. Control any external bleeding you can see. If you can give IV access and fluids, not your scope, rapid transport is key. Yes, facilities are dispensary, let's provide surgical or chest tube inversion. Okay. The best option if dispensary cannot provide interventions beyond what you already do it, bypass and head direct to the trauma center while stabilizing and root. If patients are less, local arrest protocols, but diagnosis is poor without surgical intervention. Sorry, this is prognosis, yes. Keep it at home, and key things, yes. But yeah, potentially here you're dealing with a tension in the thorax, and that's what this is probably looking at. Yes, and manage, but yeah, here you bypass dispensary and go straight to the trauma center. I noticed that in case of a 1-year-old convulsive patient, you gave Phenytoin fast. No, yes, then Phenobab, when asked to defend one's stress, how would one do that? Okay, let me put that question on chat. Uh, so I'm just gonna take a bit of history first. Let me just delete this. Uh, this 1 year child has is very interesting conversations for everyone. All right, let's do this. So let's start with what is the protocol pro, uh, protocol for managing a 1 year old child with status, no status epilepticus anyway. Status epilepticus. All right. Yeah, ABC, ABC, check your sugars, give benzo, do not give more than 2 second line. So phenytoin, valproate, levetiracetam. Then third line is where you get into your phenobut. Now, Anonymous has asked, okay? So this is an anonymous question. Phenytoin first, then phenobut. When asked to define one choice, how do one do? It's not a local guidelines, okay? What? So question is also local guidelines. Local guidelines by who? See, it's also important. So let's look at WHO. So if we say WHO is the standard guidelines for managing patients, then we can say what is the WHO protocol for this? And give me link. Give me the link. Okay. So now it's yes. So now it's giving me the WHO protocol. Experiencing electricals, intravenous diazepam, quality evidence low, strength and if persistent also benign intravenous valproate, phenobub, phenytoin. So you can give phenobub, as I said. So WHO protocol says you can either give phenobub or phenytoin. Okay. Choice depends on local resource availability, capacity of monitoring in children, as moderate and commercials. Okay, and so yes, after benzo, these are the clinical. And if I want to go find the source for this, first line anesthesia medicines for management activity. So I can go into that website and click. So if the question is when asked to defend one choice, you can easily say these are WHO protocols and here's the information from WHO. Yes, and you can click on the link and read more information on anesthesia medication WHO. All right, good. Next question. 72 year old. Let me take Ellie. Julia and her patients. I'm getting to you, Julia. No referral facility. Oh, delete. Hi, new chat. Okay. So vomiting, confusion, lethargy, admin monitoring passage for the last 1 week. Abdominal station. In the emergency department. I have a feeling I need more information here, but let's continue. Let's see. Tremulous with abdominal extension in the emergency department. What are my differentials? And how do I approach this? So clinical problems, subacute, 1 week concentration, ultimate of Guria. Huh. So the tremor is probably asterixis. Okay, asterixis now brings a whole new discussion. Toxic metabolic encephalopathy, most likely to renal, hepatic, or metabolic derangements. Okay, so renal causes acute kidney injury, hepatic causes hepatic encephalopathy, chronic liver disease, portal. So and that's why he has the abdominal distension, ascites, abdominal distension. Okay, so here, renal, nothing, uremic encephalopathy, lethargy, doesn't explain abdominal distension. So let's check. So ABCs, do your blood tests as usual, liver function tests, all these tests. Um, Put a catheter in. I'm suspecting, let's see, in your patient, let me see. Vomiting, confusion, lethargy, minimum acid. So, tremulous, abdominal extension, joint extensions, and approaches. Okay, so I'm thinking hepatic. Uh, what other clinical signs should I look for if I think it's hepatic? Jaundice, all right. So is it jaundice? Is it wasted? Does it have a sweet misty breath odor? Asexis, flapping tremor, classic hepatic confusion, confusion to lethargy, construction apraxia, inability to copy simple figures, but he's too confused, I'm sure, to copy anything. Hyperreflexes, so I need to check his reflexes. I need to check his abdomen for shifting dullness, fluid trail, hepatomegaly, check his liver, splenomegaly, caput medusae, oh, I check look for that. And remember, I can ask this AI to give me images. It just takes a long time for it to generate images. So I'll probably do it as a last thing. So that you can see images, how images can be created. Hi, hepatic flap, confusion, encephalopathy. All right, so putting it together, if I find this, then it's probably hepatic. All right, so that definitely need liver function test, liver ultrasound, and a few other blood tests and my electrolytes to confirm this. All right, so good. So Kevin Kehara, would you be okay with a Neuralink implant? Now you're not. No, I don't need an implant. I just need to use my brain and the AI, and then I'll be Neuralink. Just like thanks, Kevin. Uh, so let's look at the next question, next case. We're almost done with this shift. It's been a busy shift. Done. So Julia and her baby, who has no referral facility. All right. So uh wait, BLS ambulance. Wait, what are we talking about? Let's see. So there's no referral facility. I think Julia, you need to clarify which case that one has no referral pass. The above patient developed left-sided weakness, hands. Oh, Irene is back with her patients. Okay. Let me bring Irene's patient back. Julia, can you clarify which patient you're dealing with now? Um, there's so many cases now. Sorry. Irene, let me take Irene's case. I'm gonna delete this. Hi. So Irene's case is where is that chat? Irene Odipo. Here we go. So we have that, and then you're saying blood pressure, left side weakness, hands and limbs. Okay, where is the brain stroke lesion? Let me just check whether your symptoms still correlate with a stroke. Uh, left, it's just a right motor cortex would cause left face and arm weakness. What's your language involvement on left hemisphere? The mouth deviation to the right concentric left lower motor facial, far from our left hemisphere. A mouth deviation, left hemisphere, stroke, particularly in frontal. MCH to involve the frontal lobe, that region of the brain. Uh, could this be a link? Let's check that one. Uh, but this case features pointing to an organic cause rather than yes. So aha, so you can see object, so you can do trickiness detectable with that. So you can even differentiate. I'm like, okay, let me just check this for again. Gauge disturbance, features headaches, muscular pathology, inconsistencies, deficit, give away weakness, patient suddenly lets go instead of slowly graded effort, no objection, no findings. All right. in this case, that is just was stroke. Okay, so patient is not malignant. Good job. All right. Uh, Views of AI and other modalities such as imaging, interpretation, point of care ultrasound. Yannick, yes. But the imaging, there are tools that can do AI interpretation of images. And yes, maybe we'll do a different session for that one. Jimmy, good question. All right, let me bring that. So this is Jimmy's question. So I'll ask this differently. ECG is normal on arrival. Um, how do I know if it is safe to discharge the patient? Okay, high risk features, so that loss of consciousness, chest pain, abnormal ECG, da 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 da. If ECG abnormal, admit. So if the ECG is normal and no high risk features, those are the high risk features. As you can see, everyone recommends observe patient for 6 hours with a repeat ECG. If repeat ECG remains normal and the patient remains asymptomatic, discharge is reasonable. Additional considerations, if you really is not required, remember skin not required unless chest pain. Da, 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 da. It tells you what is when and how. Discharge only if reliable follow-up in your patient, normal exam, normal, no. If exposure is low voltage and remains well within a normal PTCG for 6 hours of monitoring, it's generally safe to discharge. Clear return precautions. Do not discharge immediate triage. Yes. Okay. I think that's a key one there. Do not send them far away. Enda nyumbani. Yes. Okay. You need to be to monitor the patient. All right. Good. All right. Next case. Um. uh, Okay. Fast. Let's do this one. All right. Delete. Okay, so that's a case. 30-year-old male, history of methanol ingestion of 99, on admission to the ED, but walking and talking. How do I manage this patient in my rural ED? Ah. So patient is kind of talking and talking, but enter close for deterioration, coma, seizures as part of failure, IVR as needed. If available, we don't have this. We have electrolytes, we can do that. Um, we don't have that. Blood glucose, no function tests. Antidotes. Antidotes are by, so preferable. So, of course, we don't have that. Ethanol, ifomeprazole. So this is the ethanol infusion. Okay. So I'm gonna give this. But suppression is what can be used to maintain certain rough dose, 1 ml per kg of 40% ethanol as loading dose, maintain it at that. So my patient is talking, eh? So is the ethanol. So here's a good question. I don't have IV ethanol, but can access Smirnoff vodka. Oh, maybe go down here. Indications for dialysis. Nah, okay. Hi. Vodka is typically 40% alcohol by volume. That means 40 ml ethanol per 100 ml vodka. Maintain serum that. Okay. Loading dose, oral or nasogastric, 1 ml per kg of vodka. Yo, they'll be very happy. So 70 ml vodka, 3 shots. Okay. Maintenance dose is 14 to 28 ml per hour. Um, Giving dose in divided dosages every hour to keep the patient slightly intoxicated. So you're keeping the patient slightly intoxicated but awake and protecting the airway. It's a very good yeah. So give it in divided doses every hour. Don't just give them shots. Yes. Okay. So administration tips, best give an NG tube for accuracy. dilute with juice or water to make it more tolerable. Taken orally, monitor vomiting, aspiration, hypoglycemia, hypothermia, other consider, consider you must give this folinic acid. If you have access to bicarbonate if you have access to a blood gas, then you can give bicarb. Fluids, supportive fluids, seizure control. The patient needs dialysis though. Urgent dialysis needs available, especially since vision loss with your card. So, um, oral vodka is not ideal, but life-saving where these other things are not there. But let me see. So dialysis, what are the indications? So indications for hemodialysis, how if possible. So we just quickly jumped to vodka. But yes, so if you don't have IV, this we can give vodka, give thiamine, okay, if or pyridoxine. Correct acidosis, that's if you can get your pH done. Seizure control. So if your patient is already an indication for dialysis, you have visual symptoms, so they definitely need to go for dialysis. I'm sure you're not able to measure methanol levels but yeah, dialysis. So yeah, so Kefas, once you finished giving, as you give them vodka, send them for dialysis. All right, answer live. Yo, done. This one. Okay, Julia, thank you for bringing that up. What do I do? Let me delete this. So here it's not, you can't be, there's no refer. Okay. Uh, there can't be no referral facility. It's more like a distance thing. Nearest, nearest, let me just say, a big hospital, nearest big hospital is an hour away. Because yeah, you can't say there's no referral facility. Where are you? Yes. Um, okay, so it goes to the same thing we had discussed earlier. Yeah. So your BLS, so do that, monitor signs, call the hospital, um, to prevent others as dispatching crew. Um, yes. Yeah, so you still have to take this patient to the hospital. There's nothing else you're gonna do. Yes, unless the question not clear on the question being asked. Um, just see answer live done. Yeah, so patient has to end up in a proper facility. Single ambulance too with BLS limitations, patients at high risk of cardiac arrest. So you will have to just do what, and you can ask. So interesting, if you do this on the phone, you can ask them to give you would you like me to draft a structured BLS through action plan? Yes. So as you're one away from your hospital, you can ask it to do this for me. So this is my action items. Scene safe, tick, tick, tick. Airway breathing, BVM in case of duration, give oxygen, uh, background mass ventilation, pulses, monitor, establish ABS with BLS protocol, give cautious fluids, monitor patient, vitals every 5 minutes. Call the hospital, request ALS intercept if possible en route. If patient stops breathing, start bagging. If there's no pulse, start CPR with an AED as per BLS protocol. Hand over at hospital, do an ESPA. Yes. So treat time, likely diagnosis, P or cardiac event, when otherwise, yes, there we go. All right. Good copy, Philippa. Let's see. Hmm. All right, we have a few more cases. This shift has to end at 8:30. Yes, even ED people need to go sleep. All right, let's check. 20-year-old male who swallowed 20 tablets of action tablets. Each tablet is 7 milligrams of aspirin, and the patient is alive and vital stable. How should I manage this patient in the ED? In the ED. Yeah, so the ED is going to shut down at 8:30. Aspirin, so 10, so 12 grams aspirin, 6 grams paracetamol. Okay. So toxic dose for aspirin is for 70 kg, 10 grams portion left, 12 grams is the potential. So he's already definitely aspirin toxicity. For paracetamol, toxic dose is that, 600, still concerning. All right. So 6 grams in a 70 kg adult is not concerning. So then we're worried about more aspirin toxicity. But yes, of course, paracetamol is behind the scenes. Okay. Stable vital signs, time of ingestion. Of course, do those levels if we have access to those. We don't have access to this at least. Let me put, okay, so I'll put that we don't have access to those tests later, but let's continue. Uh, give charcoal within 1 hour of activation, beyond 1 hour limited value. Okay, so at least charcoal will be faster. Fluids, calorization, maybe start sodium bicarbonate, hemodialysis. Okay, so what I can say, if you something, no. So my NAC levels are not toxic. So a paracetamol are not toxic levels. So should I still give NAC? Uh, um, do not wait for levels. Okay, so our levels were not more than 50 milligrams. Sorry. So what if I say I do not have this and uh, tests. So we don't have those tests available. Okay. So I'm gonna do that. Give you a charcoal. No level up. He ingested 6 grams, which is borderline toxic in a healthy, because you cannot measure level. The safest approach is to treat empirically. Okay, fair enough. Give NAC. That continue NAC. If the patient is asthmatic, go delayed hepatitis is possible. Okay, so LFTs and glucose daily for 2 to 3 days. Okay, so if that remains fine, they're good. So aspirin, severe range. Since you cannot monitor the levels, you must learn people features on acid-base status. Key risks is metabolic acidosis, hypokalemia, pulmonary edema, CNS toxicity. So start your bicarb. He develops this if the patient has acidosis, he has any of these symptoms, and that's what you start. So most likely a patient's having tachypnic and all that. So measure urine pH if possible. Keep potassium levels, so check that. If you can, if your patient's renal failure, pulmonary edema, CNS changes, even without drug levels, patient is dialysis. Of course, admit to HDUSC and all those. Here are some practical levels to think about, and you can get an algorithm. All right, so good. So the key thing is you need to tell AI everything for it to make decisions that are practical in your setting. All right. Who is Ellie? You had okay. Let me find your patient. Ellie has complicated his patient. Okay, so there is one. Okay, so then so this is the last patient. Please don't send another patient. We are shutting down. Yes. And so, uh, and care first, I'll get back to you. So, 70-year-old patient, this is the patient we had um, abdominal distension. Beside focus reviews a full bladder, the pyocystitis and hydronephrosis, as well as prostatic enlargement. Transurethral calcification is access with production of filters of turbid urine and later hematuria. Okay, so let's see. Story has changed. Yeah, give all the information. Again, people give the information. Don't give it in bits and pieces. All right. Skillfully balanced and anticipate post-operative diuresis, monitor electrolytes, maturia, urine for culture, start antibiotics. So, looks like your patient has urosepsis. Check renal function tests. Causes likely benign PPH, urology referral, and so yeah. So don't hide information from the AI. There's a new bladder now. But yeah. So a patient has urosepsis. Has it said we start antibiotics somewhere? Mhm. Okay. Da, 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 da. Infection money. Aha. Surgery for culture. So yeah, here we go. So we need to start ceftriaxone plus minus metronidazole as per local antibiogram just for renal function. Um, Uroseptic fluids antibiotics are considered ICU unstable. Yes, sounds like our patient was already unstable, and that's what we need to do for this patient. All right. So, let's go to Kefas's patient because he's now made him up. So this is the last patient of the shift. Then we can go home. So, new chat. Then Kefas has complicated the patient. Yeah, a few hours later, convulsions. How do we manage the convulsions? Yeah, methanol poisoning complicated by seizures, a late and serious complication usually. So your ABCs, start your benzos as first line. If persistent, give phenobarb. Okay. Avoid phenytoin. Okay. Ineffective for toxin-induced seizures. Yeah, actually, plus also phenytoin increases your QT and does so many things. So if you're thinking toxin-induced seizures, don't give it phenytoin. Correct underlying causes. So these are the same things we had discussed earlier, and that's your treatment for this patient. All right. That's a lie. And we've managed 20 cases. Yes. So thank you all for joining. The key thing here, as I said, is we need to move away from bad medicine. Okay. The practice of guessing what to do with your patient, the practice of guessing drug dosages, the practice of providing inaccurate patient management in 2025 is gone. Okay. You have tools. And remember, I just use one tool, and there's so many other tools you can use. But I just use basic chat GPT, and there are fancier tools that are coming out that you can use to manage your patients. The good thing is if you set up your chat GPT account and as an emergency care provider and keep providing emergency care questions, it learns you and then is able to always give you the accurate answer. You need to create the account and own that account to be able to provide the information that then the chat GPT knows what you're doing. And cool things is you can always ask, give it protocols, ask for protocols, and yes. So 2025 best practice. Just as a catch, we are trying to introduce AI on the casualty app that should be coming. Yes, but for many reasons. But the key thing is, yes, no more guesswork. Let's practice evidence-based medicine. Let's use AI. No guessing about patients. And with that, thank you for joining us. I think we have an exciting session next month. And as always, every last Thursday of the month, we have these sessions where we're trying to improve emergency care practice. This video will be uploaded by Daktari Online and will also be available on our YouTube channel and website. Share with your friends. Please do not keep this information to yourself. Let's make sure that we are providing best care to patients across board. Uh, yes, Joshua, if conversions are vigorous about giving benzodiazepines, Joshua, I'd say check it out. Yeah, answer your question for that one. Thank you, everyone. Cheers. Bye.